Now we are moving to the 11th question. Question is, an 82-year-old female undergoes reverse total shoulder arthroplasty. Intraoperatively, a nerve is injured during glenoid preparation. Which of the following depicts the most commonly injured nerve during the step of the procedure? So, nerve injury in glenoid preparation is axillary nerve. Now we have to find which is the axillary nerve. So B is the axillary nerve. So we have to identify the other nerves also. We have to know the anatomy of the brachial plexus. This is the axillary nerve from the posterior cord. This is the radial nerve. Then this is the musculocutaneous nerve. This is the median nerve coming from the lateral cord and medial cord. And this is the ulnar nerve which comes from the medial cord. So we have to remember that the nerve injured in glenoid preparation is axillary nerve, and the most common cause is neuropraxia only, though, so we can wait. Going to the next question. 22 years old volleyball player reports the insidious onset of superior and posterior shoulder pain. Superior and posterior shoulder pain. X-ray is normal. MRI is showing. So MRI, humeral head, glenoid, there is a cyst here. This is axillary pouch. This is normal. This is axillary pouch. And there is a cyst in suprascapular notch here. So in suprascapular, nerve palsy can cause weakness in external rotation due to the weakness of infraspinatus muscle. So in overhead athletes, there is high risk of posterosuperior labral tear, which can lead to paralabral cyst. It is a posterosuperior labral tear associated with a spinoglenoid cyst that is seen in MRI. It can lead to weakness of infraspinatus, resulting in weakness of external rotation. What nerve is most commonly injured in the condition? The condition is anterior shoulder dislocation. So the nerve most commonly involved in anterior shoulder dislocation is axillary nerve, because its course is around the cervical neck of humerus. You can see an illustration here. The axillary nerve passes around the cervical neck of humerus, so it is more prone for injury in anterior shoulder dislocation. Next question. 19 years old male is playing football and he has a pop in the left knee during a tackle 12 days ago. He was unable to return to the game and reports large amount of swelling in the knee. On examination today, he lacks full extension. So means lacks full extension can be a patellar tendon rupture, but it can also be present in bucket handle tear of the meniscus. It can also be a quadriceps tendon rupture. Then we have to go to the MRI. In the MRI, this is medial meniscus, but there is no lateral meniscus present here. This is the PCL attachment on the femoral side, but there is the lateral meniscus can be seen here. Now going to the sagittal section, lateral meniscus posterior horn is not visualized. So it's a bucket handle tear of the lateral meniscus. So we have to go for an arthroscopic meniscus repair followed by immediate joint mobilization. Nowadays, prolonged knee mobilization is not advisable in meniscus repair patients. It's a lateral meniscus bucket handle tear, but bucket handle tear is more common in medial meniscus, but this case is lateral meniscus bucket handle tear. This is the arthroscopic image showing bucket handle tear and repair. Next question. 62 years old female that presents with complaints of worsening shoulder pain. You discuss with your attending physician several potential causes for this patient's advanced joint destruction. There is destruction of the joint. Which of the following is the most common etiology of the neuropathic arthropathy of the upper extremity? So we can see that humeral head is almost destroyed and there is calcification around the shoulder joint. So it is a neuropathic arthropathy of the shoulder. So syringomyelia is the most common cause for shoulder neuropathic arthropathy. So syringomyelia leading to destruction of shoulder joint. So most common cause of syringomyelia is Arnold-Chiari malformation. So we have to go for a MRI, cervical spine MRI, to assess for the syrinx. Neurosurgical decompression is indicated in the presence of syrinx. It can compress the lateral spinothalamic tract, leading to pain and temperature sensation loss. Next question. 17 years old male presents with left knee pain and swelling after playing football 3 days ago. On physical exam, he has a large effusion with limited knee flexion due to pain. This radiograph shown figure A. What does the finding in the radiograph present? So here we can see that there is a chip fracture. This is an avulsion fracture in the lateral tibial plateau area. So this is an anterolateral ligament avulsion fracture, which is most commonly known as Sagon fracture. This is a Sagon fracture, which is most commonly seen in ACL injury. Which is a Sagon fracture. This ALL is attached to tibial plateau anterolaterally. So we can understand the anatomy. This is the fibula collateral ligament. This is the anterolateral ligament, which is the thickening of anterolateral knee capsule, which is proximal and lateral to the Jerdis tubercle. Going to the next question. 22 years old female sustained a lateral patellar dislocation while playing intramural soccer. This is her third dislocation in the last 6 months. She completed 6 weeks of physical therapy following her first dislocation. You recommend reconstruction of her EMPFL given her recurrent instability. Where should be your femoral tunnel? So this is one of the most common questions that we should be aware of. This is Blumensatz's line, and this is the line for posterior femoral cortex. So the shortest point, the femoral attachment of EMPFL should be proximal to the Blumensatz's line and anterior to the posterior femoral cortex line. So this is the shortest point. It's a shortest point. Recommended location for femoral tunnel for EMPFL reconstruction. Recurrent patellar dislocation should be operated, and it is most commonly treated by MPFL reconstruction, but treatment has to be changed according to other parameters also, which we will be discussing later. Which of the following patients is optimal candidate for latissimus dorsi transfer? So for a latissimus dorsi transfer, there should be done in an active patient. A massive rotator cuff and associated supraspinatus atrophy. Should not be done in arthropathy patients. It should not be done in thoracodorsal nerve palsy because it supplies LD muscle, and so latissimus LD transfer is indicated in young labor with a massive rotator cuff tear and atrophy of supraspinatus fossa. It is a reconstructive option for irreparable posterior rotator cuff tears, which can regain the external rotation of the shoulder. Which of the following statements regarding rotator cuff repair is true? So this is the true statement. Bone anchor drilling enhances the vascularity following rotator cuff repair. Shoulder motion following rotator cuff repair should not be restricted to enhance the blood flow. So it is a false statement. Double rotator cuff repairs do not have a better clinical results in studies. Subacromial decompression does not increase the rates of successful rotator cuff repair. Next question. A 22 years old collegiate pitcher having a pain and decreased velocity of throwing, he is examined in the office and diagnosed with glenohumeral internal rotation deficit. This is also a very important entity that we have to know. There is in overhead athlete, there is a condition called as glenohumeral internal rotation due to posterior capsule tightness. So posterior capsule will be very tight in overhead athletes and it will cause internal rotation deficit. So in these patients, we have to do stretching called as sleeper stretches, which will help to stretch the posterior capsule of the shoulder.